Good afternoon, everybody. It is my pleasure to introduce Dr. Michael Liu. Michael is a really good friend of mine, so I'm always really happy when he comes to Berkeley and we can visit. We never run out of things to talk about. Michael is currently the Senior Associate Dean for Academic, Student, and Faculty Affairs at George Washington University's Miliken Institute School of Public Health. That's a mouthful of a school. He, prior to that, was the director of the Maternal and Child Health Bureau for the U.S. Department of Health and Human Services from 2012 to 2017. He led a federal bureau with an annual budget of more than $1.2 billion and serves more than 57 million women, children, and families nationwide. During his tenure there, Dr. Liu transformed key federal programs in maternal and child health, launched major initiatives to reduce maternal, infant, and child mortality in the United States, and was awarded the prestigious Hubert M. Humphrey Award for Service to America. I would add that we have at least 2 training grants from that organization. Our NCH training grant, but many of you may be supported by that or at least benefiting from, and public health nutrition training grant. And we have for a very long time been funded by HRSA and Dr. Liu's NCHB organization. Dr. Liu joined the federal government from UCLA Schools of Medicine and Public Health, where he held a joint faculty appointment in OBGYN and community health sciences for nearly 15 years. While at UCLA, he brought in more than $50 million in research and training grants. He was best known for his research on racial and ethnic disparities in birth outcomes and his leadership in developing, testing, and translating a unified theory of the origins of maternal and child health disparities based on the Lifecourse perspective. He received his undergraduate degree from Stanford, his MPH from UC Berkeley, go Bears, and his MD from UC San Francisco. Michael is not only an incredible visionary about maternal and child health and the Lifecourse, but he also is one of the most, how do I say it? He's really a great person. And you know, when you hear about academics who are this accomplished, sometimes those two things don't go together. And in Michael's case, they really do go together. So I really have a lot of gratitude that he's my friend, and I'm just thrilled to share him with you today. So thanks for coming, Michael.
Thank you, Margaret, for that introduction, and so for all your leadership, partnership, and your friendship over the years. And thank you all for showing up. My understanding is that Thursday is the new Friday, and Friday is the new Saturday now. And so to have this turnout on a Saturday afternoon is pretty incredible. So I flew in at this time to do a tape recording.
I'm sorry, just turning this down.
Okay.
We got in trouble.
Uh-oh. Can you hear me back there? Okay. I came in this time to do a tape recording for an online module for Julie Deerdorf, and then she thought that since I'm here, might as well give a talk. So we talked about kind of what I should be talking about, and since she thought that I have a pretty interesting life and an interesting career, that I might just talk about my life and my career and share some of the lessons learned along the way. Now, I do have to say that you know you're getting old when people start to ask you to share your life lessons. I just hope that I'm learning enough in my life course to actually make it worthwhile for you on a Saturday afternoon. All right, so I'm going to take us back 52 years to, let me see. I'm going to take us back 52 years to Taipei, Taiwan, where I was born. So this is me as a baby. It's actually the only baby picture I have. And I was born to parents who never went to college. In fact, my mom, she actually never went to high school or even junior high. See, my mom was only 11 when her father died, so as the oldest girl in the family, she had to drop out of 5th grade to go work in the factory to help support the family. So, and when they first got married, my parents were still pretty poor. The first home I was born into had no running water, no flush toilet. We didn't have health insurance because there weren't such things as health insurance back then. Right? And so when you get sick, and unfortunately I was sick a lot as a child, that you never knew how much the doctor or the medicine was going to cost. And so from time to time, my parents had to make that difficult choice between paying for food and paying for medicine. At one point, my mom sold her wedding ring to pay for my medicine. So I certainly didn't come from wealth or privilege, but there was probably something else that I got from my family that was perhaps more valuable. So I learned everything I ever needed to learn about grit and hard work and sacrifice from my dad. And I learned everything I ever needed to learn about love and empathy and compassion from my mom. They worked hard all their life to raise a family, to put food on the table, and to put their 4 children through college, including my 2 brothers graduated from UC Berkeley, and see their youngest son go from that tiny little apartment on the other side of the tracks in Taipei where family 6 was crammed into, to be selected last year as one of the 75 most influential alumni in the best school of public health in the world. I used to think that I beat the odds in spite of my background. But as I get older, I start to think, well, perhaps I beat the odds because of my background. Right? So yes, this is a story of resilience. It's not my resilience. It's a story of intergenerational resilience. And it's actually not that uncommon a story. If you listen carefully, you'll find it in many of the immigrant families that we work with. Families who left everything behind, set forth for the distant shore, looking for a better opportunity, better life for their children. Families raising children with special healthcare needs, fighting battles every day to give their children a fighting chance of reaching their fullest potential. Yeah, I think in maternal and child health, and certainly in public health, there's a lot that we can learn about where resilience comes from these families, but only if we're willing to listen to their stories. I also think that my background gave me a purpose, which may explain what I ended up doing with my life. It gave me a North Star to follow, and to work hard every day to give every girl, every child, a fair shot at reaching their fullest potential. Kind of fair shot that my mom never got, and the kind of fair shot that too many girls and kids both in this country as well as around the world don't ever get. I would just have to say that it's been a real nice North Star to follow. And from time to time, when I lose my way and get all caught up in the pursuit of status and power and wealth, it's been nice to be able to have something to come back to, have a North Star to point my way. So one thing that I would encourage you to do this weekend, when you do get a moment, is to sit down and write down your mission statement. Okay? And from time to time, go back and check on it, make sure that you're still doing what you set out to do. So I do think that it's important to anchor your life with a clear purpose. So, so we came to this country when I was 11 years old. We actually moved out to Concord in the East Bay. And right away, I just fell in love with this country. Right? The freedom to become anything that you want to be. well, almost anything. There's me wanting to grow up to be a pitcher for the San Francisco Giants, but my fastball just never got fast enough. But given my background, I never for one day took my education for granted. So just knowing what a special privilege that I've been given. I just remember like just how excited I was the first time I got to look inside a human body in my anatomy class. Probably the same excitement that some of you have, but perhaps made a little more special just because I know that I'm the first in a long line of my family who ever got to like look inside the human body. And decades later, I haven't stopped learning one single day. I still read for hours before I go to bed every night. And I do think that thirst for knowledge, that love of learning, took me far in education. So it took me to Stanford for college, where I studied political science and human biology, and that really kind of started my lifelong love affair with interdisciplinarity. Then it took me to Harvard, where I studied public policy at the Kennedy School. And then I came back to the Joint Medical Program, where I got my MPH in epidemiology and my MS in health and medical sciences, and my MD from UC San Francisco. And while I was at the JMP, my classmates and I started a clinic called the Suitcase Clinic, and still there, still standing after about 30 years, almost 30 years. And the reason we called it the Suitcase Clinic is, we had this idea that we were just going to carry a suitcase full of medicine and go with our attending to like People's Park and visit homeless people wherever they were. And we pretty quickly found out that wasn't what they were asking for. That was for a whole constellation of problems for which they deferred their healthcare, and that we really needed a very different model. So we started recruiting students and faculty from the law school to provide legal counseling. We recruited students and faculty from the psychology department to do crisis intervention. We recruited students and faculty from the public health school to do program planning and implementation. And we recruited students and faculty from the optometry school to fit eyeglasses, and we recruited students, lots and lots of undergraduate students to serve as case managers to take our clients to their referrals. And then we have volunteers from the community. We had a chiropractor, we had a dentist, and we had a barber. And every Tuesday night, when we opened our door, and back then it was at the First Presbyterian, I don't know if it's still there would be a line of like about 50 homeless people line up to come in, not to get healthcare, but to get their haircut or to get their manicure, and then they find out that there's healthcare available, so they go and get their toe infection looked at or get their cough treated. So that was kind of really my first introduction to social determinants of health, and it really kind of broadened my notion about what being a doctor is all about. It reminds me of something that Jack Geiger, who founded the first community health center, said once when he was questioned by a government bureaucrat why he was using federal funds to prescribe food instead of medicine, and he said that the last time I checked my textbooks, the specific therapy for malnutrition was in fact food. And while I knew we were making a difference, it always kind of bothered me that it felt like we were just putting a Band-Aid on the problem. And it just never made sense to me that we were treating somebody for their asthma or for their bronchitis, and then we just throw them back out on the streets again. Seems like in the richest nation on earth, we should be better than that. It does kind of remind me of a quote from one of my preceptors back then, Rick Levine, who paraphrased a quote from Primo Levi. And the way he put it was that the mark of a civilized society is that it does not allow the powerful to become too powerful and the weak to become too weak. So I graduated from UCSF and then went to UC Irvine to do my OBGYN residency, and then joined the faculty at UCLA right out of residency, where I held a joint appointment between the medical school and the School of Public Health for about 15 years. As an assistant professor, you really just chase kind of where the money is or where the data is. And so I was floundering a bit. I really wasn't doing anything inspiring until one day, one of my senior colleagues stopped in my office and asked if I could stand in for him to give a talk to a statewide summit of county health officials around racial and ethnic disparities in birth outcomes. And I said, sure. And I still remember this vividly. As he was leaving the office, kind of turned around and he told me, just tell them it's all about socioeconomics, which was actually a very popular explanation at the time, right? That the racial disparities in birth outcomes was due to socioeconomic differences. So as I started pulling data and my slides together for the talk, I came across something that was somewhat unexpected. Sure, African-American women with a college education have better birth outcomes than African-American women who didn't go to college. But African-American women with more than 16 years schooling still have a much higher infant mortality rate than white women with less than 9 years of schooling. I want you to pause and think about this for a minute. Okay? We're talking about African-American women who graduated from college, who've gone on to grad school, med school, law school, business schools, other JDs, MDs, MBAs, and PHs. We're talking about African-American doctors, lawyers, and business executives, and they still have higher infant mortality rate than non-Hispanic white women who either were high school dropouts or in this case, never went to high school in the first place. So it couldn't be just all about socioeconomics, right? So as I started digging kind of deeper into the data, I was realizing that the data just kind of really didn't support some of the most popular explanation at the time. So for example, a very popular explanation at the time was that the disparities were due to genetic differences. And yet we know that foreign-born Black women had infant mortality that was about 1/3 lower than US-born Black women. And in fact, foreign-born Black women had babies with a birth weight distribution that actually is more closely resembles that of US-born white women than US-born Black women. So that would argue against a purely genetic explanation. And another very popular explanation at the time was that behavior, that the disparities were due to differences in internal behavior, such as smoking. And yet we know that more white women were smoking cigarettes during pregnancy than Black women, and that African-American women who didn't smoke still had a much higher infant mortality rate than white women who did. So it can be all about smoking. And then prenatal care, again, very popular at that time, so popular that it actually shaped our national policy for more than 2 decades. But then again, we know that African-American women who started prenatal care in the first trimester still had a much higher infant mortality rate than white women who started prenatal care after the first trimester or had no prenatal care at all. In fact, there were several studies back then that like looked at all of these different risk factors during pregnancy simultaneously that continue to find this residual black-white disparities that are not explained by all of these risk factors. In fact, there was one study that looked at 46 risk factors during pregnancy and found that they only explain less than 10% of the variance in birth weight. So this is kind of really where we were around the turn of the century, that after decades of research, all we could explain was less than 10%. And that's when I started thinking, well, maybe we're looking at this all wrong. If you think about what we've been doing is we've been taking a snapshot of a pregnant white woman and a snapshot of a pregnant black woman, and we've been trying to explain the differences in their birth outcomes based on these snapshots too. Of course, we're not going to explain very much, right? Because we might know how good their nutrition is during pregnancy, but we don't really know anything about their preconceptional nutritional stats. Or we might know how good their prenatal care is, but we don't know anything about their healthcare access across the life course. So I thought, well, perhaps the way to look at disparities is not by comparing these snapshots during pregnancy. Perhaps the way to really understand disparities is by comparing their life course experiences and exposures. And that's kind of really the origin of the life course perspective that Dr. Halfon and I and my colleague at UCLA kind of wrote this paper that was published in the Maternal Child Health Journal back in 2003, where we call for a re-examination of racial ethnic disparities in birth outcomes from a life course perspective. And the life course perspective was really kind of built on two major concepts: early programming and cumulative pathways. So early programming model posits that experiences early in life, including those that when you were just a baby inside your mother's womb, these early life experiences can influence your health and function for life. And this is really built on the work by David Barker and his colleagues in England, who through a remarkable series of studies actually found this relationship between being born at low birth weight and increased risk for heart disease, hypertension, and diabetes. Now, if I were to ask you, tell me some risk factors for heart disease, what would you count? Cholesterol, obesity, smoking, hypertension, low birth weight? How many of you will tell me about low birth weight? What does being born low birth weight have anything to do with your risk for heart disease 40, 50 years later on? So what Barker and his colleagues hypothesized that there are these sensitive or critical periods during development during which the function of an organ or system is being programmed, and if things don't go right, if something goes wrong with that fetal programming, then that organ or system will never function optimally over the entire life course. A very simple mind example is that if you were to get undernutrition in the second trimester, when the pancreas and the kidneys are rapidly growing, you end up with a smaller pancreas with fewer beta cells, or smaller kidneys with fewer nephrons, and that may increase your susceptibility for diabetes or kidney diseases later on in the life course. Now, as you can imagine, the Barker hypothesis was met with a great deal of skepticism and even some ridicule initially. But over the last 3 decades, there's been just this tremendous growth of scientific evidence that's beginning to support this whole notion of fetal programming. And at the time, I thought, well, if that's the case, could pregnancy complications like preeclampsia or preterm birth also have a fetal origin? That is there such thing as fetal programming of your future reproductive potential? And and so certainly over the last few decades, one of the most exciting things that's happening in research is all the advances that we're making in terms of understanding epigenetic modification and its relationship with fetal programming. Now, most of you know epigenetics, which is kind of basically volume control for genes. Right? You can turn up or down. You can switch on or off your gene expression based on your environmental exposure, especially those exposures during critical periods of development. And there are different mechanisms by which that can happen, but one of the most common way is you can simply put a chemical tag. Okay? So you see that molecule there with 1 C and 3 H's? For those of you who still remember your college chemistry, what's that? It's a methyl group, right? So you can put that methyl group directly in front of that gene, and that blocks that gene from being expressed. Alternatively, if you were to remove that methyl group, then that allows the gene to freely express itself. So generally speaking, methylation turns off, turns down, silences, blocks gene expression, whereas demethylation, taking away that methyl group, turns on, turns up gene expression. And I love to use this slide as an example to illustrate the importance of epigenetic modification to fetal programming. Okay. So what do you see on this slide? Mice, right? You see some, I don't have a pointer. Do I have a pointer?
You can try.
All right. You see some blonde and chubby mice, okay? And you see some brown and slim mice. Do you believe these mice are actually genetically identical? And all of these mice carry a gene called the agouti gene, which turn their fur coat blonde. The same gene also causes them to overeat, which then confer a high risk for obesity, diabetes, and cancer later on in their life course. But despite being genetically identical, researchers in the study were able to turn these mice from blonde and chubby to brown and slim simply by feeding their mothers a diet rich in folic acid nutrients. Folic acid? Well, you all know about folic acid and neural-tube defects, right? But what does folic acid have anything to do with? Well, it turns out that folic acid is a very rich methyl donor, right? Got a lot of methyl groups. So moms ate a diet rich in folic acid, basically methylated, turn off, silence that obesity gene before her pup was ever born. So imagine that, someday being able to tell our patients that we know how to turn on those genes that's going to confer upon your baby good health and longevity, and turn off those genes that's going to cause cancer and heart disease and diabetes before your baby is ever born. It's no longer the stuff for science fiction anymore. Right? And in fact, I think the cancer doctors are about 10 years ahead of us. They're already figuring out how to turn on those tumor suppressing genes and turn off those tumor promoting genes. Although I do have to caution you against extrapolating too much from one animal study, right? Because not all humans are rats. But this is certainly one of the dozen earliest examples of how early nutrition can influence your DNA, your DNA methylation, and that such epigenetic changes can have lifelong and perhaps even intergenerational impact on health, in fact, and function. And the second concept, key concept that we built the Lifecourse perspective on is something called the cumulative pathways model. And what the cumulative pathways model says is that chronic stress, and we're talking about in terms of biological stress, okay? So that could be stress from poor nutrition or stress from chronic infection and inflammation, as well as psychological stress, and that could be stress from the experience of poverty or average childhood experiences or violence or even racism. Right? So chronic stress can create wear and tear on your body's organs and systems, which over time can lead to a deterioration in your health and function. And how does that happen? What happens to your body when you're under stress? What happens when you see a saber-toothed tiger? You run, right? And what helps you run faster is your body activate that fight or flight response, that activate that hypothalamic pituitary adrenal or HPA axis and the sympathadrenal medullary system. You're putting out all of these hormones to help you run away from the tiger. Now, what happens after you got away? Your blood pressure comes down, your pulse comes down, and you relax. And that's the amazing thing about the human body, that it's self-regulating. It knows to shut itself off once the stressor has been removed. And that's what we call allostasis, to maintain stability through change. How many of you have heard of allostasis? And no, I think every one of you has heard of homeostasis, right? So allostasis is a concept that's very much akin to homeostasis, that whereas homeostasis refers to your body's ability to maintain equilibrium within a very, very narrow range of biological variability, for example, maintaining your body's potassium level, allostasis is really a more dynamic concept that refers to your body's ability to adapt to environmental change. And allostasis works by a negative feedback mechanism that's common to many biological systems. Okay? It works very much like a thermostat. So let's say that the room temperature falls below a preset point. What happens? Thermostat kicks in the heat, right? But as soon as that preset point is reached, what happens? The heat turns off the thermostat to prevent this room from being overheated. It turns out that same thing actually happens inside your body, so that when you're under stress, your body activates the HPA axis to produce cortisol. Cortisol in turn feeds back negatively onto your brain to shut off the HPA axis to keep your stress response in check. So that's allostasis at work, maintaining stability through change. So allostasis works well for stress you can either fight off or run away from. What happens if there's nowhere to run? What happens if you can't get away? You get eaten, right? But what happens if you don't get eaten? We know that in the face of chronic and repeated stress, your body loses that ability for self-regulation, and now you can turn on, you can shut off. Biologically speaking, what may be happening is get this tonically elevated level of cortisol start to downregulate glucocorticoid receptors in the brain, so you lose that negative feedback. And we find in animals and humans who are subjected to chronic and repeated stress, they actually walk around with higher circulating levels of stress hormones. If you were to subject them to some natural experimental stressors, that they put out a lot more stress hormones than people naturally would. And that's when you start to go from being stressed to being stressed out. There's actually a big, big difference here. Okay, this is the difference between protection and damage. Because under acute stress, your body activates a sympathetic response to increase your cardiac output, right? The amount of blood that's pumped out by your heart every minute to help you run away from the tiger. But when you're stressed out, you can't shut off that sympathetic response, and that chronic, uncontrolled sympathetic activation over time can lead to hypertension and cardiovascular diseases. And under acute stress, your body activates the HPA axis to produce cortisol. And cortisol is a glucocorticoid, and one of the main functions of glucocorticoid is actually it converts your body's stored energy into glucose, which then becomes readily available fuel to help you run away from time. And it does that partly by impeding insulin action. But when you're stressed out, you can't shut off that HPA axis, and all those excess glucocorticoids over time can lead to glucose intolerance and insulin resistance. Under acute stress, your immune functions actually work better. But as most of you know, under chronic stress, you become a lot more susceptible to infections and inflammation. Now, the way to think of this relationship is think of the HPA axis as a set of brakes on your immune system. Okay? So if you're chronically stressed out, okay, that's like driving around with your foot on the brakes, right? What happens to a car when you drive with your foot on the brake? You know, I hate to drive behind people who drive like that. Right? The car just doesn't run very well, as in the case of depressed immune function and increased susceptibility for infection. And if you keep driving with your foot on the brakes, what's going to happen over time? You're going to wear out those brakes, right? And now you have a much bigger problem. Can't stop the car, as in the case of runaway inflammation. Okay? And think about all the chronic diseases in our society today that are characterized by excess runaway inflammation. Name some of them. Hypertension, diabetes, heart disease. And think of all the chronic diseases that are characterized by a great deal of racial disparities. Lupus, nephritis, all the autoimmune diseases. And do you think that chronic stress may actually play a role in the pathogenesis of chronic diseases and the origin of health disparities in our society today? And then lastly, under acute stress, you actually get growth of neurons inside your hippocampus and the prefrontal cortex. These are learning centers inside your brain. It's almost as if they're designed to help you learn from your mistakes. And that's perhaps why I think many of you could still remember vividly exactly what you were doing when you learned about 9/11, right? Even though you can't remember what you had for dinner last night. And that's because under acute stress, you get growth of neurons in these learning centers. But under chronic stress, the exact opposite happens. So rather than growth, you get atrophy and death of neurons inside your learning centers in the brain. And that's why women who are under chronic stress begin to report that they're becoming more forgetful, that they're losing their memory. Bruce McEwen at Rochester University provides perhaps the best illustration of these concepts of allostasis and allostatic load in this cartoon here. Okay? So in this bottom picture here, okay, this is a picture of allostasis, right? Two kids balancing on a seesaw, maintaining stability through change. But what if I were to replace these two 5-kilogram kids with these two 500-kilogram sumo wrestlers? You put so much stress and strain on that seesaw that sooner or later, the seesaw's going to break. Now, what if a woman were to enter pregnancy carrying these two 500-kilogram sumo wrestlers on her back? She's not going to have a very good pregnancy. So basically, kind of based on all of this, Dr. Halfon and I proposed that birth outcomes are the end product of not only the 9 months pregnancy, but really the entire life course for women leading up to the birth of the child. And that disparities in birth outcomes are the consequences of not only differential exposures during pregnancy, but perhaps more importantly, differential experiences across their entire life course. So if we want to do something about improving pregnancy outcomes and reducing disparities, what do we have to do? We've got to start taking care of women and families, not only during pregnancy, but before pregnancy, between pregnancy, and really across their entire life course. And we got to do a lot more than just healthcare. Right? We got to address kind of all the social determinants that create all that kind of wear and tear, that allostatic load, that impact on early programming I talked about, and create the social conditions in which all women, children, and families can be healthy and thriving across their life course. And then as a follow-up, several of my colleagues around the country and I, several years later, put forth kind of this paper a 12-point plan to close the black white gap in birth outcomes. And I'm not going to go over all 12 points, but certainly the first 4 points around interconception care, preconception care, prenatal care, ensuring healthcare access across the life course. These 4 points move us beyond our current focus on prenatal care to start to address the healthcare needs of women and families across their life course. The next 4 points around strengthening father involvement, enhancing systems integration, creating reproductive social capital, and investing in community building. Okay, these 4 points move us beyond our current focus on trying to change individual behavior to start working on strengthening families and communities. And the last 4 points around closing the education gap, reducing poverty, supporting working families, and undoing racism. Okay, these 4 points move us beyond our current focus on the biomedical model to start addressing the social and economic inequities that underlie much of our health disparities. So then in 2012, I left UCLA to join Health and Human Services as the director of the Federal Maternal and Child Health Bureau. Now, how many of you have heard of the Federal Maternal and Child Health Bureau, MCHB? So yeah, as Barbara said, yeah, MCHB is really the one federal agency that's responsible for improving the health of all America's children and families. I had a staff of 200, annual budget of $1.2 billion, and a portfolio of about 100 different programs that touch the lives of more than 57 million women, children, and families each year. So as the director of that one federal bureau responsible for improving the health of all of American children and families, it really bothered me that so many kids and families are doing so poorly in this country. We are the richest nation on earth, and yet we consistently rank near the bottom among developed nations on those standard measures in child health. I really thought that we could do better. So during the 6 years that I was there, we worked really hard in improving, innovating, and transforming not only the Bureau, but the MCH in this country. So much so that some folks on the outside tried to call us the Make Change Happen Bureau, MCHB. So we led the transformation of the federal Title V program. How many of you have heard of Title V? Good. This is really good. And Title V is kind of basically the public health system for all children and families in this country. Right? And with more than $650 million in federal budget, and with state match and overmatch, the federal state Title V program is a $6 billion enterprise each year. It really is one of the best levers that we have to lift up the MCH population, one of the best vehicles that we have to drive improvements in child health in this country. So the Title V program was started under Title V, the Social Security Act in 1935, and then it got converted to a block grant in 1981 under the Reagan administration, which actually gave the states a great deal of flexibility. Right? And maybe rightly so, because certainly the needs of families the needs of kids and families in California are very different from those of kids and families in West Virginia. So Title V actually gave the states a great deal of flexibility. But over time, some states mistook that flexibility as a blank check to the states and really just kind of did whatever they please kind of with the money. And so with each state doing its own thing, it was actually really hard for me to tell a coherent, compelling story about what Title V was doing and what difference it was making. And so the first year I got there in 2012, Congress proposed to cut the block grant by $250 million. And then the next year, our own administration, right, this is the Obama administration, proposed to cut the block grant by $350 million. In essence, it was kind of a vote of no confidence for the program. So we knew we had to change, right? So I led the states and all the stakeholders in a collective kind of visioning process. So we had town halls, we had listening sessions. Now I got over 1,000 emails and I read and responded to like every single one of those. And it took us about 21 months, right? But we finally got all 50 states to a common vision about the future of the Title V program and to agree to 15 national performance measures by which they're all going to be working toward moving the needle on over the next 5 years. And for each one of those performance measures, we insisted that the state come up with an action plan that's guided by a clear logic model and informed by the best science and best evidence. And we also kind of completely revamped our National Survey of Children's Health, from which is the data source for many of the performance measures. So we go from a survey every 4 years to a survey every year to annual survey so that we can track in real time what's working and what's not, and to really help drive real-time improvements for the states. Okay. So in the process, we transformed the block grant from what was perceived by many as a blank check to the state to perhaps one of the most evidence-based, the most results-driven block grants in federal government. And Congress took notice. So the same appropriation committee that tried to cut us by $250 million, not only did they not cut us, but in the last few years have actually added more than $50 million to the block grant because we were delivering results. We led the transformation of the Healthy Start program. Now, how many of you have heard of the Healthy Start program? Sort of doing great on MCH here. The Healthy Start program is basically the largest federal program to reduce infant mortality in this country. We have a budget of more than $100 million. We work with more than 60,000 families in 37 states and the District of Columbia. Now, the Healthy Start program was started back in 1991 under the first Bush administration, and back then Congress actually put a preference clause into the legislation, which means that year after year, the same grantee got funded, no matter whether they were producing results or not. In fact, when I first got there, I found out that one of the grantees was getting $1 million, and we weren't actually quite sure how many families they were serving. And so when I started asking questions about that, I was warned that, nope, don't go there, because they were the constituents of a very powerful senator. Mm-hmm. So we decided to take on transforming the Healthy Start program, and largely so that practice can catch up with where the science is, right? So we have 5 major focus. One, I was talking about, you want to improve the women's health, not only during pregnancy, but before, between pregnancy and across their life course. 2, improving the quality and safety of maternity care. 3, strengthening families, including fatherhood. 4, addressing social determinants through the collective impact model. And 5, improving accountability. So for the first time, we instituted 22 benchmarks by which we're going to hold our grantees accountable. And for the first time, we have a real competition in probably 20 years. As you can imagine, the rollout was a bit bumpy, and about 1/3 of the grantees, existing grantees, did not get refunded. So for About a year after that, I was hauled into congressional offices for whipping quite frequently by the members whose district lost funding. I still think that we did the right thing, right? And we let the results do the talking. And I'm proud to say that within the first 2 years after the transformation, the program serving many more clients, many more families than it ever did in its previous 25 years. And the infant mortality rate across these 100 sites between 2015 and 2016 over a 24 months period was 5.0 deaths per 1,000 live births. So considering the fact that these programs have to be eligible for the program by having a baseline infant mortality rate 1.5 times that of national average, and that 96% of them actually had an infant mortality greater than 10 at baseline, to go from 10 to 5 in just 2 years. That's almost kind of unheard of, right? So I just finished telling you about kind of being skeptical about data. So I was kind of worried that how much I can really trust the self-reported data. So in 2017, we actually went for the gold standard. So we worked with National Center for Health Statistics. We used linked birth death certificates. We worked with CDC plans. So we oversampled kind of these communities. And so for the first time, we have a scientifically rigorous evaluation plan so that we can clearly demonstrate the impact of the Healthy Start program, which I'm dying to find out what the final outcomes is by next year. Now, lastly, we also took on transforming the Maternal Child Health Bureau. Now, this is a bureau that had a long and glorious history, right, kind of dating back to the establishment of Children's Bureau back in 1912, so more than 100 years. And in its early days, it fought for child labor law and early infant care. In the 1950s, it led the expansion of immunization. In the 1960s, it led the expansion of newborn screening. And in the 1970s, it really helped deinstitutionalize children with special health care needs, right? Brought them home and get them fully integrated into the schools and communities. And that's why I love the Bureau so much, right? It's got such a tremendous legacy of making a difference for kids and families in this country. Then over the last decade or so, they really have been on a steady decline. Some folks said that it's just kind of becoming old and tired. Some critics said that it really kind of become a pass-through agency, like money in, money out, really no value add. That it's really kind of becoming irrelevant in MCH policy. Now, I didn't believe kind of all of it, but I do think that some of it was on us. Certainly, kind of when I first arrived, that we had staff members who were coming in at 11 o'clock and leaving at 2 o'clock, and no one said anything about it. And probably the best example of kind of what was going on was that within the first couple of weeks I was there, I got this funding opportunity for an epilepsy program that's funded at $1 million a year. It's got this kind of little sticker on it that says, sorry, this really should have been posted 2 weeks ago. Could you just please sign it? Do I get to read this first? So I asked the project officer to come in and talk to me about the program. And I said, well, you've been running this program for about 10 years now. What difference have we made? What impact have we had? And then the project officer said, well, we really didn't include evaluation as part of the funding opportunity. So we didn't ask the grantee to do that. So we really don't have any outcomes to demonstrate. I said, well, at least tell me how many kids are we serving. Right? And she said, well, we didn't really keep track of it. So I said, I'm not going to sign this until you get some data for me. So she went back to the grantee, and they went back and forth for like about 3 weeks. And then finally they agreed on a number. And then she came back to me and she basically said, we think it's 25, but we're not sure if these are unduplicated numbers. I said, are you kidding me? I can fly a neurologist on a private jet to do home visiting to each one of these kids for cheaper. So we decided to cancel the program, and I'll tell you kind of more about kind of what we did. But basically, that's kind of where we were as a bureau, and the morale was incredibly low. As I mentioned, the administration was proposing to cut the block grant by $350 million. They were actually proposing to eliminate the Healthy Start program altogether as a vote of no confidence. So we really knew that we had to change. So I took on transforming the Bureau, and we focused on the 3 Ps: people, process, and products. And starting with people, because you always want to start with people, right? Because an organization is only as strong as its people, and your job as an organizational leader is to do everything you can to create the conditions to help unleash the top strengths to allow to allow each and every one of your staff members to reach their fullest potential. So we work really, really hard at recruitment, at training, at performance kind of reviews, at promotion, at communication and engagement. And we also want to make sure that we're walking the walk and not just talking the talk about diversity and inclusion. Right? So we also did a lot of kind of work in terms of outreach and trainings, including training of unbiased unconscious bias for the search committees, as well as networking and mentoring and benchmarking to keep us honest. Okay? And I'm proud to say that within about a 3-year period, staff engagement, inclusion, innovation, and overall satisfaction on the annual federal employee survey improved by more than 20 percentage points. And we went from one of the worst places to work in federal government to among the best places to work in federal government by focusing on people. And then process, and this is kind of when I first got to the Bureau, we were really more of a collection of fiefdoms than we were really kind of one bureau. Right? All the divisions were kind of working in silos, and folks out there were complaining that Title V wasn't talking with Healthy Start, and Healthy Start wasn't talking with home visiting, and so forth. But despite in the face of what I knew about our people, were probably some of the most collaborative people I knew. So it's that we have all of these structures and processes that really stood in the way of true collaboration. So we actually did a lot of reorganization and realignment so that we can break down these silos and create teamwork, recognizing as an African proverb reminds us that if you want to go fast, you go alone, and if you want to go far, you go together. And lastly, around product, that we want to make sure that for each and every one of our 100 programs, that we were able to deliver measurable impact, deliver the greatest return on investment. And that really means being able to be clear about 3 questions up front. What are we trying to accomplish? Which means having clear goals and smart objectives. How are we going to accomplish it? Which means having clear strategies that are informed by a clear logic model and the best science and the best evidence. And then what does success look like? Which means having clear metrics and robust data, and so that you can know what's working and what's not in real time. And so when people talk about result-based accountability, that's what they're really talking about. And then just to share another resource that I actually found very useful when I was trying to lead change in the Bureau and in the field, is this book called Leading Change by John Carter, which laid out kind of 8-step process for leading change, which I really found very useful. So for example, he said that one of the most common mistakes for change leaders is that they always start with the vision. Okay? He said, vision won't get you anywhere if folks are too complacent to change. That you really need to start by creating that sense of urgency, right? And there's nothing like a $350 million cut to the block grant or elimination of the Healthy Start program to create that sense of urgency. Another thing he said is that once you have a clear vision, you want to make sure that you communicate and communicate and communicate even some more what your vision is. And then you want to communicate not just to the head, but to the heart. And he said that a very common mistake for change leaders is that they start with the how and the what instead of the why. Because most of us just start, well, this is what this is what we need to do, and this is how we're going to do it. So you really need to start with why change. And there's actually this this TED Talk about Dr. Martin Luther King Jr. and I have a dream speech. So on that hot summer day in 1963, on the steps of the Lincoln Memorial, Dr. King could have given a very different speech. Right? So instead of saying that I have a dream, he could just say, I have a 5-point plan. So it would have been a fine talk, I'm sure, but it would have been, probably wouldn't have the same kind of effect in terms of transforming the conscience of the nation.
Just ignore me.
So I was really having a lot of fun at the Bureau. We were already planning to launch a moonshot for NCH in the Clinton administration until the election happened. And I don't mean to make this a partisan message, because the work that we do at NCHB has always been bipartisan. In fact, some of my strongest supporters have been the Republican governors in some of the deep red southern states. There's just something very, very different about this administration, especially given my background, the travel ban, Charlottesville, and the bigotry, the hatred, the racism that's been unleashed upon this land by the politics, policy, and rhetoric of this administration, really just not something that could work for. So I resigned from the Trump administration about a year ago and joined GW, School of Public Health. And I know for some of you, as it has been for me, these seem like dark days for our republic. We seem to be getting farther and farther away from that more perfect union. And it just all seems like our nation may be going in the wrong direction. And it's easy in times like these to just start to get cynical about our future, to get disengaged from the political process. I just want to close today by saying that it's exactly times like these that we have to keep on working, to not give up, believing that our nation's best days are still ahead of us, believing that the arc of a moral universe is long, that it will bend toward justice, and we're here to bend it, believing that one day this nation will rise up and live out the true meaning of its creed, and we hold these truths to be self-evident, and we're all created. And here I'm reminded of something that my friend Mark Peck, was a former founder and CEO of CityMatch, did one year during her sabbatical. She went around the country and interviewed all of these great heroes of public health in the 20th century. So people like Julius Richmond, who started Head Start, the people like Bill Fahey, who helped eradicate smallpox on the face of the earth. After she did all of these interviews, Magda said that there was one thing that she found assured in common by all of these heroes. One characteristic that characterized all of these greatest heroes of public health in the 20th century. Want to guess what it is? She called it an unwarranted optimism. Okay? They stay optimistic in good times and bad. Here I'm also kind of reminded of a parable that I learned as a child growing up in Taiwan about an old man who one day just decides, with the help of his family, start to dig away at this mountain that obstruct the way between his home and his field. And I know this is a little environmentally incorrect, but just go with me with this parable. Okay. So when mocked by a wise man about the futility of his effort, the old man simply replies that I myself may not succeed in moving the mountain, but my children and my grandchildren will continue the effort, and one day the mountain will be moved. So let's start digging. Let's move mountains. And if you found like nothing helpful, like no helpful life lessons in the last hour, let me give this last ditch effort here. Okay, the one final message to take home, which is to don't stop believing. So we gotta keep on believing, because that's just who we are. That's what we do in public health. We have to keep on believing because there's so many women, children, and families that are counting on our leadership. And let me just give you one more reason to keep on believing. So I told you about my story, my background. I told you about my mom, how she had to drop out of 5th grade to go work in a factory to help support the family. How she once had to sell her wedding ring to pay for my medicine. So I certainly didn't come from an educated family or a wealthy family. But none of that mattered anymore once we came to this country. And that's because I actually got to live a version of America I think many of us still believe in. Because in that America, you don't have to be rich to go to the best schools. And in that America, everyone gets a fair shot, no matter where they're from, the family they're born into, or the color of their skin. And in that America, I knew that if I just work hard enough and try hard enough, I can give my children a better chance in life. The kind of chance that my mom wouldn't even ever dare dream. And that my two girls, the granddaughters of a girl who had to drop out of 5th grade to go work in a factory, can now grow up in a nation where they get to be anything they want to be. That's what truly makes this country great. But if my girls can get a fair shot, why shouldn't every child in America get a fair shot? If my girls can get a chance, why shouldn't every child get their chance? So this is the version of America that we believe in. This is the America that we're fighting for. In America, where everyone's created equal. In America, where everyone gets a fair shot. So you and I, or maybe Barbara, you and I, we might not get there ourselves, but we'll just keep on digging, and we'll keep on believing, and one day our children and our grandchildren will get to that promised land. And ultimately, that's what our work in public health is all about. So, thank you.